Good evening, good afternoon, and good morning, everybody. This is Dr. Mohit Bhandari, consultant bariatric metabolic surgeon from Mohit Bariatric and Robotic Surgery, Indore in India, along with Professor Fobi, welcoming all of you for the 20th episode of Virtual Bariatric University. And we are coming up with a very common yet interesting topic, the laparoscopic sleeve gastrectomy, a bariatric metabolic operation for this particular episode. Let me introduce you with the faculty which we have today. We have Dr. Paulina Salminen from Finland. Paulina is a professor of surgery in University of Turku in Finland, and she's also a chief of acute care surgery in Turku University Hospital. She is editor-in-chief for the Scandinavian Journal of Surgery and JAMA, and also the editorial board member for the British Journal of Surgery, Lancet, and World Journal of Gastrointestinal Endoscopy. She had been the president of the Finnish Foundation for Surgical Progression, which she is at present now, which is ongoing, and also the Finnish Obesity, Metabolic and Surgery Society, and also was an active member of the Joint Continuous Medical Education Committee and Committee General in 2015 for this society. Welcome to the Virtual Bariatric University, Paulina. Next, we have Professor Jacques Himpens, past president of IFSO, one of the most famous surgeons from Belgium. He's a professor of surgery associated with the University Hospital from Belgium and has the honor of performing the first laparoscopic gastric bypass in Belgium in 1999. Also the first laparoscopic sleeve gastrectomy followed by BPD or the DS in 2001. Jack has performed over 15,000 bariatric procedures. He has trained more than 40 fellows. He has many patents on his name. He's also an honorary member of ASMBS and, as I already mentioned, a past president of IFSO. He is a co-editor for obesity surgery and also in SORD is one of the most sought-for reviewers. So Jack, welcome to this show. We look forward to interact with you. We have Dr. Sandeep Aggarwal from India, from AIIMS. Sandeep is a close friend and he is a professor of surgery from Department of Surgical Discipline at AIIMS. He pioneered bariatric and metabolic surgery and started this department in AIIMS. He's also a council member in Obesity Surgical Society of India. He is a founder of the FORMS, which is the metabolic bariatric surgery teaching platform. He has conducted many meetings through that platform, which are very nicely and very enthusiastically organized by him, attended by many surgeons and faculty members from across the globe. One of the cadaver courses which he is usually conducting through this platform is very much appreciated and a lot of surgeons learn from it. Also, he is editor of many PubMed index journal like JMAS and also on the editorial board of Obesity Surgery, a very active researcher and one of the most voracious and avid publisher in the field of bariatric and metabolic surgery, which Aussie has. Welcome, Professor Sandeep Aggarwal, to this show. We have Christine Stier from Germany. Christine was trained as a surgeon in Munich under Professor Mayer's department. 2012, she joined Professor Rudolf Weiner as a senior surgeon and then worked with him. Today, Christine leads one of the most prominent bariatric department at Sana Obesity Center Community in North Rhine in Westphalia. She's one of the chairs of the German Obesity Alliance and vice chair of German Metabolic Endoscopy Association, members of IFSO Bariatric Endoscopy Committee, and the editorial board member of Obesity Surgery. So welcome, Christine. This is a very interesting topic and your inputs and insights on this particular show will be very much appreciated. To add more, I have another friend, another great leader from Austria, Professor Gerhard Prager. Gerhard is a member of Compacted Commission Investments of General Hospital in Vienna, Medical University of Vienna. He is members of IFSO, ASMBS, and obviously the Austrian Society for Surgery and Austrian Obesity Association. He was the president-elect of the European chapter of IFSO 1820. The Austrian Society for Obesity and Metabolic Surgery. He was a past president in 2018. He's on the editorial board of both Obesity Surgery and SORD. And has contributed to numerous articles in the field of obesity surgery. Gerhard is a great friend and he's one of the most prominent leaders in this field from Austria. So welcome, Gerhard. I hope you are doing well, and it's nice to see you here. We have another friend, Catalin Copaescu. Catalin is general and GI surgeon and head of general surgery from Romania. He's an executive director at the Bucharest Surgical Training Institute, president of Romanian Association of Endoscopic Surgery, which he held until 2019, president of the 23rd EAES International Congress, president of the National Bariatric and Metabolic Surgery Symposia in Bucharest. And I have attended 3 of such symposia with him, been a faculty member at his symposia. They are fantastic and one of the most sought for, which surgeons look forward to attending from across the world. He was also the regarded as the bariatric surgeon of excellence by IFSO European chapter. And in 2014, the bariatric surgeon of excellence from Surgical Review Corporation, also the hernia surgeons of excellence from the SRC USA, also the colorectal surgeon of excellence from SRC USA. So his specialization is not only bariatrics, but the excellence goes beyond bariatric into hernia and colorectal, involved in 23 grants and more than 133 original research papers published. Catalin, so proud to have you on this show. Welcome. We have Dr. Ken Lowy from Australia, another great friend. Ken is a specialist upper GI surgeon at St. George Public Private Hospital. He has performed more than 3,000 advanced laparoscopic surgery, hold the position of regional chairman for NSW RSCS and also the secretary treasurer to the IFSO APC. Currently, he holds the advisory role with the Department of Health and Aging in facilitating new bariatric surgery item number classification and National Case Mix Classification Center in funding for bariatric surgery in Australia. Very important piece of work being done by Ken. Ken has extensive experience not only in bariatric surgery, but also upper GI laparoscopic surgery, including hernias, colorectals, and several others. So welcome, Ken. Welcome to this show. You have come for the first time to this virtual bariatric university, and me and Professor Fobi, we are honored to have you. I have my friend from India. It's an honor to have Dr. Ramesh Makam from Bangalore. Ramesh is currently at Fortis Hospital in Bangalore. He's a senior consultant and head of bariatric metabolic surgery, the pioneer of bariatric metabolic surgery in Bangalore and Karnataka. He's a world-renowned surgeon who runs the Bangalore Endoscopy Training Institute, and most of the young surgeons have been trained under him at BEST, involved in many surgical innovations, EndoTrainer, virtual reality equipments to train young surgeons. He was the first one to establish a dedicated fellowship course in the field of bariatric and metabolic surgery by Rajiv Gandhi University of Health Sciences in India. And he is a founder member of the Hernia Society of India. Welcome, Ramesh. I hope you're doing good in COVID times, and it's an honor and it's a pleasure to see you here on this show. Myself and Professor Fobi, we are honored to have all of you on this show, and I look forward to interact with you. We have a live case lined up for all of you. So let's start the show without much delay. I would like to invite Gerhard, Catalin, and Ken, and Dr. Ramesh to moderate the first lecture session. Thank you, everybody.
Thank you very much, Mohit, for this kind invitation. I think we start immediately, and it was extensively already the CVs explained. I just want to add that I'm very grateful to Paulina. She's a very active member of the IFSO European Chapter Scientific Committee, and I'm always very glad about her input. And of course, she published the sleeve pass trial, maybe one of the landmark papers dealing with sleeve, and I look forward to hear your talk, Paulina. The stage is yours, please.
Good afternoon to everybody from Finland. My name is Paulina Salminen. I'm a professor of surgery at Turku University Hospital and University of Turku. And I'm very grateful for Professors Fobi and Bhandari for this kind invitation. And my topic is long-term weight loss outcome and resolution of metabolic comorbidities after sleeve gastrectomy. These are my disclosures. And the topic content is a challenge to squeeze into 10 minutes, but I'm lucky to have excellent co-speakers covering all of the other aspects related to sleeve gastrectomy. So I will focus on the title given and the weight loss outcomes and resolution of metabolic comorbidities, and I will use my 10 minutes focusing on the evidence provided by our RCTs comparing sleeve and gastric bypass. In order to overcome some of the criticisms associated with RCTs being performed at expert centers and maybe in a selected patient material, we did do a combination of our 5-year outcomes by merging the data on an individual patient level. The original trials were published in 2018 in JAMA for the 5-year results of these two RCTs, which are very similar with the study design and the concept, despite the fact that we did not know of each other at the time we initiated these trials. This merged data analysis was accepted last September for publication in the British Journal of Surgery, but unfortunately is still not available online, hopefully in the near future. For our sleeve pass trial, we had 240 patients. We started our patient enrollment a bit after the Swiss trial. Our trial was designed as an equivalence trial, aiming to assess whether the weight loss would be equivalent between these two procedures at 5 years, and using the definition for weight loss was % excess weight loss as the primary outcome. We had 240 patients, and the Swiss trial, the SMBOSS trial, started a bit earlier but finished their enrollment a bit later, and they had weight loss as their primary outcome using the definition of % excess BMI loss with 217 patients, with a comparative study design without specific predefinitions. In the original reports of the 5-year data, there was no difference in weight loss between the procedures in these separate RCTs, neither in our sleeve pass trial nor the SMBOSS trial. These are the spaghetti plots that JAMA wanted us to do for all of the papers in that special issue, and it really nicely demonstrates the individual variability of the weight loss outcomes that you can see in both of the trials. For the merged data, we ended up with almost 400 patients with a very high follow-up rate of 87% at 5 years. And as these were separate RCTs, merging the data aims, of course, to overcome some of the limitations and add the generalizability of the results in a much more generalizable population than just a single RCT. So not an actual meta-analysis, as we did not do a formal meta-analysis, but this, of course, hopefully improves the generalizability of the results. The difference between the two trials at baseline was the fact that the Finnish patients were older, they were heavier, and had more comorbidities, especially type 2 diabetes. So this may be one of the explanations that the trials separately had somewhat different results. By merging the data, we did retrieve new data for the merged outcomes, and we chose to approach this from a superiority assessment with a hypothesis that the weight loss would be superior after bypass. So we chose the excess BMI loss to be the primary outcome. We did retrieve new data for type 2 diabetes, including type 2 diabetes duration, preoperatively, and type 2 diabetes medications. We also reported the obstructive sleep apnea results, which were lacking from the original sleep pass trial. And we did approach the complications by using the comprehensive complication index based on Clavie and Dindo classification, also aiming to assess the burden of complications and not just the number of patients with complications. Going into the results, the merged data outcomes at 5 years for weight loss, you can see % total weight loss on the left side and % excess BMI loss on the right side. And with the merged data, the percent total weight loss, there was a difference, but this was already in the separate RCTs, but this was a secondary outcome for those trials. And for the excess BMI loss in the merged data, the difference was 7 percentage points. So the weight loss was greater after bypass. But when you looked at the weight loss curves at all of the time points, so 1, 3, and 5 years, they are very similar at all of the time points. The difference is very similar throughout the follow-up time. For the remission of metabolic comorbidities, for type 2 diabetes using the very strict ADA criteria, meaning that the patients, for complete remission, you had to have the HbA1c below 6%, fasting glucose less than 5.6, and no diabetes medications. And then for partial remission, below 6.5 and below 6.9 for fasting glucose. Using these criteria with the very much similar baseline type 2 diabetes prevalence in both groups, there was no difference in type 2 diabetes remission. Complete or partial remission was achieved after sleeve in 50% of the patients at 5 years and in 56% after bypass. As noted in many previous trials, the longer preoperative type 2 diabetes duration was associated with lower type 2 diabetes remission rates, and there was a significant difference there between the two trials. For hypertension, dyslipidemia, and sleep apnea, you see the results on the right side. No difference in dyslipidemia or obstructive sleep apnea, but there was a superior remission defined by the use of antihypertensive medications. So superior remission of hypertension after bypass compared to sleeve gastrectomy, but no difference in obstructive sleep apnea or dyslipidemia. For the complications, and here I'm a bit stepping into Professor Himpens' lecture, but very quickly to show you the complications assessed by the CCI index. There were less complications, so CCI more than 0, so meaning the patient had a complication after sleeve gastrectomy. You see the percentages there, but there was no difference in the total CCI, so there was no difference in the burden of complications. No difference also in the procedure-related mortality. In conclusion, the merged data showed, compared to the original trials, that bypass was associated with superior weight loss compared to sleeve gastrectomy, but both of the procedures had a very good weight loss. So the main point would be to be able to identify the patients that for the tailoring of the procedure choice. So very good weight loss after both, but a bit better after bypass, but bypass was associated with more complications and reoperations compared with sleeve gastrectomy. Hypertension remission was superior after bypass. So these were the differences between the original reports, and as we know, having meta-analysis sometimes changes this. I wanted to quickly show you our 7-year results that were just recently published in JAMA Surgery, just for the weight loss. So you see the curvatures are very much alike throughout the time points, also including 7 years. And we did do a specific quality of life analysis for the 7-year outcomes. And in both groups, it was significantly better compared to baseline, but no difference between the procedure, and greater weight loss was associated with superior quality of life. So to conclude, this was the merged data results. This is not a meta-analysis, not an individual patient data meta-analysis that I'm really hoping that we will be able to conduct with global scientific collaboration, especially due to especially trying to evaluate type 2 diabetes remission. And I'm really anxiously waiting for our results, a 10-year follow-up. And this is, of course, specifically for GERD and Barrett's, which is an interesting topic, but out of the scope of this lecture. Thank you very much. This is our merged data group working on the paper at EFSO Madrid. Thank you very much.
Thank you very much, Paulina, for this fantastic talk and very clear message. So after 5 years, it seems that there is no difference in weight loss, but after 7 years, it's 7%. As you stated, the difference seems to stay stable. So when we look now further to the future after 10 years, what is your expectation? Is the gap becoming bigger or does it stay the same?
Gerhard, that's a very good question. And I actually kind of thought that it could have already at the 7-year point, maybe the lines, the curvatures would have been kind of a bit more separated, but they are very much alike throughout all of the time points. So I do have the preliminary data on the 10-year, but I don't know that for the weight loss. I just know that for GERDs and Barrett's, but that will be another topic, another talk, maybe some other time. But I kind of think that they will be a bit maybe more similar than they are currently. So most likely that's kind of the level that we are aiming for. Of course, you have the weight loss after all of the bariatric procedures, but I think the difference between these two kind of seems to be stable, at least in our RCT. But as stated, that's why I wanted to show you. I know the topic was for sleeve gastrectomy, but as bypass is still considered the gold standard, we wanted to do the comparison to laparoscopic gastric bypass. And we kind of know that the weight loss is a bit better. You do have, for the merged data, you have the 7% percentage points difference in the weight loss outcome. But then again, on the other hand, you have some more complications and more reoperations. So I just kind of think that we need to approach this optimal procedure choice from a very much wider perspective. It just cannot be solely for weight loss. You would need to have an algorithm that actually takes into account a lot of different factors, and that would be something that would assist us in tailoring the procedure so the patient would benefit most. And I think it's really interesting. I'm really anxiously waiting for some of the RCTs to reach their 5-year data, because by having that we would need to have at least 700 to 800 patients with type 2 diabetes to be able to show a 10% difference in the remission rate. So that's impossible. Nobody can do that kind of a trial. So the only option is to do an IPDMA, a formal IPDMA, and do a scientific collaboration, and then actually answer that question, because I think that would be very interesting to see what happens. But I think this goes into the category of the more you do research, the more open questions you actually end up having. So
you mentioned reoperations. Of course, the reoperation rate, let's say in the first 2 years, is higher after Roux-en-Y. But what about reoperation for weight regain and reflux in the long-term run? Long-term, I mean after 7 to 10 years, 15 years. What's your expectation on that?
Well, I think we should have another webinar on reflux and reflux symptoms, and maybe also because it's just not reflux or just weight loss. They're very much associated with each other. So, but this is a topic that we actually need to take into consideration, and at least inform the patients that you may end up having this. But I wish I could already tell you the results, but it's going to be interesting, I think, with the because GERD is definitely one of the issues that you actually have to put into the equation when you're trying to figure out which procedure would be the optimal for any specific patient.
Paulina, can I ask a question?
Sure.
I think me and you are like from the opposite place, north and south, and exact opposite. And my partner surgeon is John Jorgensen, is from Finland. So we're always looking at European data and the Nordic data. We always respect those data because you guys run very good trial. I guess with the intention to treat, just follow up on Gerhard, is there anyone from the group on the sleeve has been converted to bypass based on the further treatment for diabetes? And because we try to work out whether sleeve is a metabolic procedure versus the metabolic effect or the superior metabolic effect from the bypass, your trial would be able to probably have some idea to measure it. I haven't, apologize, I haven't read your paper carefully. Maybe it's already included in there.
Yeah, that's a very good question. And like I said, to really answer the question on type 2 diabetes remission, what would be the optimal procedure? As I said, we need 700 to 800 patients with type 2 diabetes, so nobody's able to, not even the Nordic countries, even though it's easier for us maybe to run the randomized trials, but still not even within our healthcare system. So that would need international scientific collaboration. But we did for the merged data, because we had the exact same question. We do have patients that have been converted from sleeve gastrectomy to bypass. And we actually wanted to do not just the intention to treat analysis for the merged data. So we did do a per protocol analysis. So we actually took out all of the ones that in the sleeve gastrectomy group that had undergone some other procedure. And then we did a comparison of the merged data that we actually had almost the 400 patients. So, but with that, there was still no difference there. But of course, as stated, it may be that we're underpowered, but we did have the exact same question in mind, and that's why we wanted to do that with Ralph. So we excluded all the ones. But I think what Gerhard is saying, 5 years is good, but we still need to have, in order to actually have the whole picture, we need the 10-year follow-up data.
Dr. Paulina, I have one question here. You mentioned about 85% follow-up in your series. That's right?
Yes.
So we normally
87 to be correct.
Okay, that's fantastic. Really great. And then because of this good follow-up, do you think there is going to be better results in patients when compared to patients who don't follow up much?
Well, that is an option, of course, because for the patients that don't really come to the follow-up visits, they can either be the ones that are doing good or just the opposite. So they're actually the ones that aren't doing so good. So of course, it really, having the very high follow-up rate, of course, adds to the reliability of the results. But I don't really think it would improve the actual weight loss results. But of course, the reliability is very different. And Professor Himpens is asking me that what were the exclusion criteria for sleeve, and I was kind of hoping that somebody would ask that, and if I could go back in time for making the inclusion criteria, I would be much more specific, because that was one of the issues that we had for the 5-year data. I mean, the merged data that we did with Ralph. So for the sleeve pass trial, the exclusion criteria was severe reflux and a large hiatal hernia. So, but really, of course, we should have had much more specific criteria for that. We just wanted to exclude the patients that had severe reflux in order to be able to kind of compare it. We did not have a very detailed symptom questionnaire, which the Swiss trial did have. But at the time of planning the study and the study enrollment, the reflux issue was not really generally that known. So unfortunately, that's something I would really do differently at this time. But to maybe overcome this limitation for the 10-year data, we did do, or we have done upper gastrointestinal endoscopies on all of the patients, and they also underwent upper gastrointestinal endoscopies prior to randomization. So we actually know which of the potential Barrett's are de novo, and we do know the situation which has happened over the 10-year follow-up. So we're trying to kind of overcome that limitation, but unfortunately the criteria were not that strict at the time due to these reasons.
Yeah, hi.
Paulina?
Paulina, can I ask a question?
Sure.
Yeah, sure. So excellent presentation. And my question is, would sleep be a good metabolic operation for class 1 obesity, that is low BMI, over the long term, 30, 35 BMI? What's your opinion on that?
My opinion is that yes, it would be, and kind of going back to what I said earlier, it's really maybe class 1 obesity. Similarly, as you cannot really evaluate the result just based on the weight loss, and for the inclusion, I think we need to have a wider perspective of all of the issues that are associated with that, because if you have a patient with class 1 obesity and GERD, that's not a good operation, of course. So, but for when you look at the 5-year results of the merged data, our patients were actually quite heavy to start with. So our median BMI was quite high in the randomized, in both of the randomized trials, and even more so in the Finnish population. So that was, they were much heavier than the Swiss.
Thank you.
Paulina, may I also ask one question, please?
Yeah, sure. Hi, Christy.
I completely agree that gastrointestinal quality of life relates a lot to weight loss, and this gastrointestinal quality of life also relates, of course, or includes reflux. So my question is, this is a question of volume resection. My question is, how comparable were those two RCTs regarding the performance of the sleeve gastrectomy in Switzerland and in Finland?
That's an excellent question. And we actually did, of course, there were 2 separate trials, but we did compare the operative technique, which I think with everybody, when you look 10 years back, during the last 10 years, the technique of sleeve gastrectomy has evolved. We know a lot of the stuff that we may not have known starting on, but for these 2 trials, we actually ended up in the conclusion that the techniques were quite similar, because the volume is, of course, a question. As much as we can say, of course, this is retrospective speculation, but that was our conclusion with Ralph.
It sounds to me that this episode started so strong, so intensely, but we have to move on. And for the next very exciting topic, I am glad to invite Professor Sandeep Aggarwal from India, with an extensive experience in bariatric surgery, as he has been underlined. And he will touch some of these very interesting aspects of the sleeve evolution, because we have discussed about the ARCT that has been started 10 years at least ago. It was another sleeve. And if these results are now so good, let's see for the next 10 years, because Professor Sandeep Aggarwal will tell us about surgical technique of and management of perioperative complications after sleeve gastrectomy in 2021. Please.
Thank you. Thank you, everyone. Thank you, Dr. Fobi, for the invitation, and Dr. Bhandari and Dr. For the introduction. And I'm glad to be, part of this webinar. Am I audible?
Yes, sir.
Okay. Okay. Right. And can you see my screen now?
Yes.
Okay. So as I said, as you know, my topic is sleep technique and management of perioperative complications. Quite a big topic for, again, 10 minutes. But I'll try to cover, give a bird's eye view of the various aspects of, the technique as well as the complications. I have no conflict of interest or any disclosures for this talk. And my case list disclosure, basically, my workload is mainly sleeve, which is constitutes about 60%, and both the bypasses now are about 20% each. So let's come straight to the technique of sleeve gastrectomy, which we all know is the most popular procedure globally. And it has evolved over several years, starting as a second stage, as a first stage procedure for a stage, bariatric surgery for super obese, those for high risk, and now as a primary procedure for morbid obesity. So we sort of put the patient in supine position in the split leg with footboards securing the foot securely, the thigh straps, to secure the patient, an abdominal belt. We typically induce a pneumoperitoneum through a supraumbilical Veress needle, and we use 4 ports: the optical port in the supraumbilical position, and 2 ports on the right side for the surgeon, and the 1 on the left side for the assistant. We always use a Nathanson retractor, which we find very useful for retracting heavy livers. So once we enter, after we retracting the liver, we create a window opposite the incisura using the energy source, and usually it's a fairly quick process, bloodless if you are meticulous, and one can quickly reach to the upper part where one has to be careful about the short gastrics. At this point, the patient is in steep reverse telemetric position. We stress on dissecting the whole left crust completely right till the medial border of freno. That is extremely important because one is to exclude a hiatus hernia, and second is to mobilize the posterior fundus completely so that we resect it fully and not leave any part behind. And then we dissect towards the pylorus, measure about 4 to 5 centimeters, and a 38-cent bougie is then inserted under vision and place. We try to place it in the duodenum. Sometimes it doesn't go so, but most of the time we will try to put it in the duodenum gently. Once it is done, we ensure there are no other catheters or temperature probes, and then we use motorized stapler, tri-stapler preferably because very hemostatic. The first fire is important, and it's important to be away from the incisura so that we do not narrow the sleeve at that point. That's the commonest site of narrowing. And then with sequential firing, as you can appreciate, we're not pulling the sleeve too tightly. One should not be very aggressive about sleeve, going too tight against the bougie because that can cause a twist. So just with gentle traction, laying the stomach flat, and then putting the staplers in the right spot, avoiding excessive traction, one creates the sleeve so that the staple line is lateral. At every step, the loose staple should be removed from the crotch so that there's no misfire. And so, once you go towards the last part, again, one has to make sure that one does not leave the posterior part of the fundus, because if you do not spread it properly, one can leave a posterior part of fundus, and that would not be an ideal sleeve. And at this point, we find this instrument to be extremely useful, the gold finger, to define the G junction, and then fire it. And as you see, we're firing it over the left crust. Currently, over the last 5 years, we've been very aggressive about the hiatuses, and roughly in 20% of our sleeves, we are repairing the hiatus. Even if there's a dimple or there's a laxity, we dissect the esophagus and the hiatus and repair it by doing a posterior choroplasty. So once the sleeve is created, we always do a leak test. This is our standard practice using methylene blue. And then again, we can appreciate a nice, sleeve, almost banana shaped, and a staple line on the lateral aspect. And following that, the sleeve is removed without using a bag, because in bag it gets crumpled. And we always close this 15-millimeter port using endovicryl. Drain placement is usually selective, but we tend to put it in most of our cases. We still feel very comfortable putting the drains, and then we remove the ports under vision. So, 1 second. So that's about the sleeve, the technique. Let's look at the complications. We all know the complications are leak, bleeding, food intolerance, which is somewhat ignored as a complication. In my opinion, it can be a very, very like a disabling complication in the early post-operative period. Then venous thromboembolism, and then others like rhabdomyolysis and others. So again, if you talk about leak itself, is a huge topic in itself, but let me just cover it quickly. We all know it's the most feared complication of the bariatric surgeons. The leak rate varies from 0.7 to 5%, roughly averages around 2.5%, but we all know it's decreasing because of the better appreciation of the nuances of the sleeve, better staplers, and other aspects. And the leak leads to abdominal sepsis, multi-organ failure, chronic gastric fistula, and increased hospital stay. And the patient requires multiple interventions, and there's a huge morbidity associated with leak. And mortality can be up to 3.3%. The diagnosis is mainly clinical, laboratory parameters and imaging are just complementary. And the symptoms, the tachycardia is the earliest symptom. Fever occurs in late leaks. Patient can have abdominal pain, left shoulder pain, dyspnea due to pleural effusion, and overall the patient doesn't look well. However, we must realize that the signs and symptoms will be delayed in the obese as compared to non-obese. And at every round, one must eliminate the possibility of leak. Whenever we see the patient of a sleep, we must eliminate our mind that patient is not having a leak. That's probably high index of suspicion is probably the most sensitive method of diagnosing a leak. Drains have a low sensitivity and not effective in drainage of collected abscesses. Drain food amylase can help and has a high predictive value. And again, C-reactive protein is also helpful in some cases. Coming to imaging, the upper GI series itself has a poor predictive value. In our own experience, the CT scan as well as upper GI are complementary. Our CT scan is our first investigation of choice in a suspected case of leak. And in case there is some equivocal findings, we do a upper GI study, and especially putting the patient in the left side down. And we've seen a few cases, a couple of cases where leak was evident on putting the patient in lateral position. So that's another maneuver one can do when there's a strong suspicion, but we are not getting the leak on the imaging. So these are some of the findings we saw. This was, the dye going to the drain, a localized, a small leak from the G junction. Again, a localized leak here, a collection in the perisplenic region. So let's look at the management part now. So management will depend on severity or the stability of the patient. The time of appearance is another important parameter, and the location. So these are the general principles of management. If patient has peritonitis or hemodynamic instability, laparoscopy or laparotomy, prompt. That has to be prompt. We can't wait for the next day. It has to be done irrespective of the time of the day. And it involves drainage of the pus and the infected material, plus a generous lavage, a feeding jejunostomy, and suturing the defect will depend on the timing as well as the state of the tissues there. If the patient is hemodynamically stable and the patient presents within 72 hours, laparoscopic drainage should be done along with a feeding jejunostomy with the suturing of the leak if possible. If the tissues are looking good, mostly within 72 hours as possible. Unfortunately, most of the leaks present after 72 hours, and then we have to, the advisable treatment is conservative. That's what we practice in our home. And what does the conservative management include? Obviously, admitting the patient, starting on IV antibiotics, giving a broad cover antibiotics, an image-guided drainage, like in this case, an nasojejunal feeding, and proton pump inhibitors. So this helps in controlling the fistula into a controlled fistula. And there is obviously an increasing role of endoscopic management, which I'll touch upon in the subsequent slides. So if you can see, this is a localized leak, managed conservatively, and after some time, the leak sort of healed. So what are the basic principles? All collections should be drained either radiologically, surgically, or endoscopically. So one has to drain the sepsis. Determine the appropriate endoscopic approach for closure, depending on the size of the defect and the expertise available. And obviously that will depend on other aspects of the tissue of surrounding the leak. Treat distal obstruction. There's a distal obstruction or a twist, balloon dilators or luminous stents will help. Remove foreign bodies from the leak site. And the success rate decreases with the interval between surgery and endoscopic treatment. So endoscopic treatment, if available, should be taken early in the course of leak rather than late. As I said, endoscopic techniques have come into playing a larger role over the last 5 to 6 years. And they can be roughly divided into closure techniques, covering techniques, and drainage techniques. Closure techniques are using over-the-scope clips, endoloop or endoscopic suture. Covering techniques with cover stents, tissue sealants, and other things, and drainage techniques like endoscopic vacuum therapy or internal drainage catheters. So endoscopy approach basically involves a use of covered stents and endoscopic internal drainage using biliary stents. And covered stents are actually probably the most promising of the various techniques of the endoscopic management. And there are better results when stents are designed for sleeve are used, like the mega stent. And like in a recent series from Poland, 13 out of the 14 patients in which stent was inserted, the leak healed with a mean time of 34 days. And nowadays there's an increasing role of drainage of the contents through the endoscopy using biliary stents. And this was a systematic review and meta-analysis of the leak and fistula of the endoscopic management. We said that for the large leaks and fistula, let's say about more than a centimeter, self-expanding stents are preferable. For smaller fistulas like over the like 5 millimeter or so, cover sort of over the scope clip can be successful in about 60 to 70% of cases. However, the stent migration remains a big problem, and that has decreased because of the use of mega stents, but again, it still remains a significant problem, even in some of the recent series. So coming to the bleeding, it can occur from staple line, omentum, short gastric vessels, port sites, or due to use of anticoagulation itself can induce bleeding in some cases. And we all know the signs of bleeding, like excessive drainage, patient has increasing pallor, restlessness, tachycardia, and hypotension. I think any episode of hypotension in the immediate post-op period or the early post-op period should be taken very seriously, because the drains may not drain, and and the sleeve has a long staple line prone to bleeding. One must remember that. So the treatment in most cases is conservative: resuscitate, stop the anticoagulation, and follow the patient with serial hematocrits, give blood transfusions if required, and re-laparoscope, especially for the early bleeding, especially on the day of surgery, and obviously when the patient has hypotension or hemodynamic instability, there's no role of sitting and doing conservative, but one has to re-laparoscope promptly. What I would like to stress is in the prevention of bleeding, because sleeve has a long staple line, just completing the sleeve is not the end of the procedure. One has to spend time looking at the spurters and the bleeders, and one must withdraw the bougie first and then look, because some of the spurters open up when you withdraw the bougie. During using the staplers, one must adhere to the adequate compression time as prescribed by the manufacturers of the staplers. Check the staple line carefully at the end of surgery. Spend some time on that. Use a Gaussy or something, and be very patiently look for the bleeding. Ask the anesthetist to raise the blood pressure, because some of the bleeders would open up when you raise the pressure. And we use clips, oversewing, or glue, and clips are very useful in this setting to control those small spurters. And obviously, buttressing material have their benefits, but they are costly. Coming to one of the common, not so common, but can be disabling complications is the food intolerance, or the vomitings, or patients unable to eat and is miserable because they are unable to eat whatever is prescribed by the dietitian. And the common causes are a missed hiatus hernia leading to a twisted hiatus, a twisted sleeve, a stricture or edema initially at the at the junction, at the angularis, or some sort of a kink. These are the common causes, and rarely fistula and leak can be responsible for food intolerance. And the problems are recurrent vomiting, dysphagia, rapid weight loss, which sometimes we should not feel happy at a patient losing weight rapidly. We should investigate. The patient complains of weakness, not feeling well, and some cases can lead to Wernicke's encephalopathy. And recently, Goles et al. Described a combination of symptoms of bloating, pain, regurgitation, food intolerance due to hiatus hernia. So what we need to do is clinically evaluate the symptoms thoroughly. Go into the dietary habits. Are they eating too rapidly? Is this vomiting real? And if the symptoms are significant, then investigate promptly. Now, one thing to remember is endoscopy, although done as a first investigation, it may be normal even in the presence of a twist or kink, because the expert endoscopists will negotiate a small twist or a kink and may be reported normal. So we need to do some barium studies and CT scans. All these investigations in combination can tell us there's a problem. Or sometimes a diagnostic laparoscopy is the only choice to diagnose the complication when all these methods are not telling us and the patient is really miserable. Management depends on prompt admission. They can't be treated on an outpatient basis. Hydrate the patient, correct their electrolytes, give thiamine empirically to prevent Wernicke's encephalopathy. It's extremely important to give them empiric thiamine and not really depend on the thiamine values. Nutritional support via NJ tube or TPN initially is required. Definitive management for mild cases, some eating behavior modification suffices, but for moderate and severe cases, one needs either endoscopic intervention in the form of dilatation or a stent, or probably surgery, sometimes conversion to bypass or strictureplasty. So some take-home messages regarding the technique. Allergy, the sleep technique is considered as simple, but I wouldn't say it's simple. It's less complex than bypass, and it's got several nuances which needs careful attention. One must use the correct cartridge based on perceived thickness of the stomach. Avoid excessive narrowing, kinking, and twisting of the sleeve. Hiatus hernia should be carefully looked for and repaired concomitantly. And in our practice, as I said, we found in about 20% of cases that we repair it simultaneously. And one must ensure good hemostasis at the end of the procedure. For the complications, consider clusters like confusion, hypoxia, and fever to be due to a leak. Leak can present subtly and yet be rapidly fatal. And a close observation and decision-making, a regular examination patient may be required. The imaging film should be read together with a radiologist. Explore and relap as soon as possible. If there is any doubt, don't wait. Do not let anybody delay the decision, suggesting more X-rays or waiting. Sorry for the error in the spelling, or waiting till the next day. The best diagnostic test is a relap or exploration. Don't over rely on imaging, especially if they're negative and the symptoms are suggestive. Do not let the sun set on obstruction applies here as well. A prompt re-laparoscopy without regard to any convenience schedule of sleep time is what is required. And denial is dangerous and delay lethal or any complication following bariatric surgery. So a post-op, discharge protocol should actually guide the patient and teach the patient when to call the surgeon, how to reach the surgeon, and what are the red flag signs for contacting the surgeon and the center for the complications, for prompt diagnosis and prompt management. Thank you for your patient listening. Thanks.
Thank you very much, Sandeep, for this talk. This is a proof of sleeve maturity to be applied wider and wider. It was a very nice technique demonstrated. And as we know, and you mentioned, efficient protocols for managing complications are known. I'm going to provoke you for prevention somehow in at least two directions, because one of the complications that were for the long term and are discussed is associated with reflux. And in this issue, we know that hiatal hernia has a role. My question is, you mentioned that you are aggressively searching for a hiatal hernia while you are operating. And we know that 50 to 60% of the bariatric patients candidates for surgery may associate hiatal hernia, and your percentage is 20%. In many of the centers, the hiatal hernia repair is less than this. I mean, you are actively going in there. So what should be, from your opinion, the right or expected percentage of hiatal hernia repairs associated with sleeve? This is the first question, please. Sandeep.
No, as a good question. As I said, the pre-operative diagnostic test like endoscopy or imaging is really not reliable. We found endoscopic reporting hiatus hernia when there were none on laparoscopy, and vice versa. So in our practice, we when we are going near the hiatus towards the upper part of the dissection, we look at any dimpling or any laxity. If the crust is peeling off the stomach is peeling off the crust very easily, or the fundus is going up, or a lot of fat is going up, we take that as probably a stronger indicator of hiatus than any preoperative imaging. And as I said, over the last, let's say, 5 years, we have started dissecting whenever we have any doubt, irrespective of the BMI or the difficulty of surgery. We would do it, and it's pretty rewarding. And once you've done it over a time, it's fairly straightforward. So I would say, even with our own aggressive technique, we have been able to find hiatuses worthy of a repair in about 20% of cases. Maybe we are missing some, or maybe we are over-treating. In fact, sometimes when I say this, people say you are over-treating. So I don't know the answer to that. So, but I would say it roughly corresponds to the de novo reflux rate. I'm not saying all of the de novo reflux are due to hiatuses, but I would say, given our approach of being aggressive at hiatus, has led to a decrease in the de novo reflux as well as de novo, hiatuses later on. So I would put it this way, based on our intraoperative detection, but I could be wrong.
What you will do for this hiatal hernia repairs? Only approximating crura. Do you think it's enough?
No. So look, we are also mobilizing about 3 to 4 centimeter esophagus intra-abdominally. I think that's also an important anti-reflux mechanism. It's just not chloroplasty. I mean, agreed, we are not doing a fundoplication, and one can do a Nissen, Nissen sleeve.
Let's see if it is lasting. This.
So
I'm gonna provoke you in another direction that is also associated with prevention, bleeding after the surgery. And you mentioned about buttressing, and you didn't demonstrate in the surgery. So what kind of buttressing are you applying? If, of course, they are materials, they are expensive, you told us about. What about overswing? What's your procedure and what's your recommendation for those who are watching us?
So I would say we're pretty happy with the current staplers with no use of buttressing or overswing as far as bleed is concerned. And in high-risk cases, especially those with cirrhosis and those with some sort of portal hypertension, although there are very few cases, we have used SIM card, but I'm not really a very big fan of buttressing material. And we're pretty happy with the current tri-stapling technologies, motorized staplers, where, so I'm pretty happy. So we're really not using buttressing, but it's obviously a lot of people use it, and I found it to be useful. But the cost and the benefit ratio, I don't think is in favor of buttressing material. That's my take on that. Let's put it this way.
Yeah, that's interesting because it was a time when buttressing was very much discussed, especially associated with sleeve. And now less and less of those who are operating are using these materials. However, overswing is widely used. And maybe we will get some answers from the other moderators and speakers who might be excited by your technique and your presentation. I had to address to you 2 questions. This is for me. I'm going to give the opportunity to the others to do.
I'll say that we'll move on to the next speaker and then we'll address more questions. So Ken, it's up to you right now.
Yes, great. Thank you, Mel. I think Mohit has done a great job of introducing Jacques already. All I can remember is Jacques is the giants of bariatric, and I still remember in one of the meetings, Jacques might know that he's against George Fielding, who at that time was very into banding, and there was a very heated debate with Harry Frydenberg, little Harry, mediating in between both guys. So that was a very good thing for us to watch. And I also remember Mel 15 years ago in Sydney, when all Australia doing banding, when we presented our first series of bypass, he's the only one that defending our unit. So I own him for that meeting. So without further ado, Jacques had a lot of experience. He's going to tell us his experience in terms of long-term management of sleeve. Jacques, you're on.
Good afternoon. Thank you for having me. I was asked to make a brief talk about late complications and reoperations after sleeve gastrectomy. There we go. So first, my case mix slide as requested. So you see that while I perform a certain number of sleeves and Roux-en-Y's and OAGBs, you see that there's a fair chunk here that consists of redo surgery, not only after sleeves, of course, but still there's still a substantial number of procedures that I must do for all kinds of reasons after sleeve gastrectomy. Here's my disclosures. Now, I would like to start my talk by referring to a paper that Gustavo Armand, was a fellow with me, published in SWORD, and that actually referred to long-term outcomes after sleeve gastrectomy. And when you see that after 11 years, about 2/3 of the patients hadn't had a conversion, you see that about 1/3 of the patients did need some type of re-surgery on the long term after the sleeve gastrectomy. And when we look at the reason why, you see that, again, a majority was because of weight issues, which means that either they hadn't lost sufficient weight or they started putting on weight after an initial acceptable weight loss. And you see that for weight issues, we actually performed 3 types of surgery. The first one was the duodenal switch, the most frequently, but sometimes we also use the Roux-en-Y gastric bypass, and in some specific occasions, we perform the so-called re-sleeve procedure. Now, talking about weight issues, this comes from a paper that we published in Annals of Surgery, I think it was in 2006, and you see that the pattern of weight loss after sleeve gastrectomy is very typical. The first 3 years, there's a dramatic reduction in weight, but then there is weight regain. And when we express that in mean percent of success weight loss, you see that starting at about 80%, we drop to about 55% of excess weight loss at 6 years. Now, is this a common phenomenon? Well, when we look at the meta-analysis that was published on revisional surgery for failure in weight loss, we see that overall, considering all the publications, about 12% of the patients did at some point need a resurgery for weight issues. In our experience, this is what it resulted. You see that some patients did pretty well initially, then regained some weight, but not too much, which made that they didn't qualify for reoperations. And when we look at the reoperations, either switch or Roux-en-Y gastric bypass, we see that initially there is not, of course, much response, because that's the phase where there was just sleeve gastrectomy. But then when the reoperation takes place, we see that the weight drops and joins the curve of the patients that were successful after a simple sleeve gastrectomy. Now, the problem is that unfortunately there is a lot of reoperations, but it's not only for issues of weight regain or insufficient weight loss. And when we look in our group of 63 patients that were seen after 11 years, you see that a large number did actually need a reoperation. And you see that this actually adds up to a pretty high frequency of more than 20%. We were not the only ones. You see that in this paper coming from the famous Prager group in Vienna, you see that a number of patients did not need conversion, which is here, but you see that another group of patients did need reoperation for weight regain, as we can see here, and then as soon as they were operated, they joined the initial curve. This is pretty much resembling what we actually experienced. Patients that were converted for reflux, you see, had actually better issues, or better outcomes, I should say, in terms of weight loss. at the same paper that we already mentioned, we see that the most common reason for revision was failure in weight loss. And that despite the fact that the revision rate was initially 10.4%, when we go up to more than 10 years, in our experience, it was the same. We have a rate of over 20% of reoperations. This comes from a very active group from Patrick Noël and Marius Nedelcu. And you see that out of 168 patients that were submitted to sleeve gastrectomy between 2005 and 2008, in this paper of 2017, you see that 23 patients actually needed reoperation, which is just about 1 out of 7. But when we look at the type of reoperation, we see re-sleeve, we see Roman gastric bypass, and we see duodenal switch or SAD. But the majority was a re-sleeve. How can we explain that? Well, we can explain that because quite recently there has been this new technique of imaging, which is the computer or CAT scan 3D reconstruction of the sleeve stomach, which allows us to actually pinpoint where the problem is. And when we see an abnormality, we can actually address that and perform a selective sleeve gastrectomy. And therefore, they came with this algorithm based around a CT scan volumetry. And they assumed that when the volume was more than 250 cc's, we could go ahead and perform a re-sleeve gastrectomy. Whereas when we have less than 250 cc's, we can go ahead and perform the procedures that we performed in our study as well, which is DS or SADI and Roman gastric bypass. Obviously, when we have a picture like this, we can assume that this is not a good outcome. There's a patient who initially had a lab band, was converted into a sleeve gastrectomy, and you see that there was a mushroom dilatation here of the proximal stomach, and it's obvious that this patient will benefit from re-sleeve. However, there's more than just fundus, of course. A very important part of the sleeve gastrectomy is the distal part here. There's two parts actually to this distal portion, which we call the antrum. There is the pyloric antrum, which is for motricity, and there is the pyloric part, which is for the initiation of the motricity and propulsing the food bolus towards the pylorus. Now, it's important to maintain this part of the stomach, whereas we have to be careful not to leave too much of antrum behind, because as we can see in this very nice study coming from Maud Robert from Lyon, we see that when we look at the total weight loss, there is a significant reduction in weight loss in patients that had their antrum excessively preserved. So we should preserve some antrum, but not too much, because then we get issues in terms of weight loss. If we look at the systematic review and meta-analysis concerning re-sleeve, we see that there is an acceptable post-operative leak rate, but there are complications and there is some mortality. So it's not an innocuous procedure. Therefore, let's focus on the other important reason for reoperating patients after sleeve gastrectomy, which is GERD. GERD has been described as in this paper as the Achilles heel of the sleeve gastrectomy. And actually, when we look at the reasons for reoperating, as in this meta-analysis from CLAP, we see that even though a majority of patients needed reoperation for weight issues, we see that a substantial number, even though it's only 3%, but still a substantial number, needed reoperation for GERD typically. When we look at GERD, there are three main causes. The first is probably just linked to the physiology of the sleeve gastrectomy, and there's no clear anatomical abnormality. But the other ones, in some occasions, we have hiatal hernia, a significant hiatal hernia developed, or there is a stricture or stenosis of the sleeve gastrectomy. Let's focus first on the de novo hiatal hernia, and we see that there's a very high incidence. This is not the best of the studies because it's a very selected group of patients, but in this selected group of patients, we see that more than 70% developed de novo hiatal hernia, and lots of them developed GERD, more than 50%, and PPI dependence. Now, instead of focusing on the hiatus, we can also focus on the sleeved stomach itself. And very often we will see that there is actually a stricture or a stenosis. And then there are different modes of action. The first one is the endoscopy. And there are an increasing number of papers addressing this issue of dilation, balloon dilation of a stenosis after sleeve gastrectomy. But there's also surgical solutions possible, The first one is the seromyotomy, where we just incise a large portion of the serosa and the musculosa of the sleeve stomach, short of the mucosa, or there's actually the segmental resection that we can do and reanastomosis, the resection of the stenotic or the corkscrew part of the sleeve gastrectomy. However, this was extensively studied in our group, and in 2013 we published in SWORD, and you see that as a bit of a busy slide, but you see that we had a nice little series of wet resections, seromyotomy, etc. The problem, though, is that when we look at the final outcomes, you see that a number of patients who had seromyotomy and hiatal repair, or seromyotomy just without anything else, or the wedge resection, like you see here, you see that a significant number of patients were not at all helped and needed actually eventually another operation, which was very often conversion to Roux-en-Y gastric bypass. So therefore, I think there's a consensus that when there's GERD, significant GERD, and almost untreatable GERD after sleeve gastrectomy, we should convert to Roux-en-Y gastric bypass. These are the initial papers that hinted towards that, but we see that throughout the literature and throughout the years, we see that for many, the best option for postoperative GERD is actually conversion to Roux-en-Y gastric bypass. And the good news is that not only does it treat GERD, but we see in this paper coming again from Prager's group and from actually a conglomerate of hospitals in Austria, we see that Barrett's esophagus may actually regress after converting a sleeve gastrectomy into a Roux-en-Y gastric bypass. And this is really good news. Now, when we look at the weight loss, weight regain, and convert to Roux-en-Y gastric bypass, we have numbers that go back more than 10 years in the study, in the work of the group of Gerhard Prager. What we have to know, though, is that when we convert a sleeve gastrectomy into a Roux-en-Y gastric bypass, it is indeed very effective for gastroesophageal reflux disease. It may make regress Barrett's esophagitis, but in terms of weight loss, as in this paper from Palmer and Mahawar that was published in 2017, you see that the outcomes are not very good. So therefore, in conclusion, when we have GERD, I think we have to make a distinction between stenosis in the sleeve or no stenosis in the sleeve. When there's stenosis in the sleeve, we can attempt endoscopic dilation. We can attempt all that kind of thing, but the end result will always be the solution, gastric bypass. When we have no sleeve stenosis and we have a hiatal hernia, we can attempt to repair that hernia. But unfortunately, you will see that very often you will have to convert to a gastric bypass anyway. And thank you for your attention, and I'm ready for some questions.
Thank you again. That's very difficult to tease out all the long-term problem. I still remember, I think if Gerhard remember when 7 years ago when he was in Australia.
Hello.
We were debating about how to convert band to sleeve and which way. And here we are again. Now we're debating about how to convert sleeve. And so surgery is like a fashion. Jacques, I think I share the same sentiment with you regarding of seromyotomy. I didn't publish it, but I had about 6 patients, I think about 7 years ago, and half of them have to need a bypass at the end as well. In your current opinion and your data, with the sleeve failure, I know this, you're probably aware that there's a lot of now people pushing towards SADIs and different type of bypass operation, single anastomosis, etc., etc. What is your favorite at the moment? Is it still full Roux-en-Y gastric bypass, or have you got any other opinion after looking at everything?
No, I think it depends what the indication is. If the indication is pure strict weight issues, and there is no such a thing as GERD that you can document, I think in our school here, what we do is we perform SADI. We used to do DS, but now we do SADIs. Not sure that's better, but it's certainly simpler for the residents. And then if there is GERD, we usually don't hesitate to perform bypass. Very recently, there's a colleague here of mine who started doing SASI, you know, the single anastomosis, gastroenterostomy together with the sleeve. But I can't tell you anything about long-term results of that one. So to make a long story short, GERD, Roux-en-Y gastric bypass, no GERD, but wait, SADI or DS.
I think that's the sentiments that are probably echoing as well. Just coming back to the hiatus hernia, I think that's part of the talk that Sandeep done before. Do you use the Nathanson's retractor? Because I found I use it routinely, but I have put up a video that is actually, you can actually create a hiatus hernia with the Nathanson's retractor if you're retracting too hard. So we have colleagues that is in our town routinely repairing it just for a little dimple, but I'm sure that once you start accessing the hiatus hernia, you destroy the phrenoesophageal ligaments and the reflux is going to happen. What's your view, Jacques?
Well, I think it's a very important point. That phrenoesophageal ligament is something you should not touch. And I think that's something that we learned from the Meester dozens of years ago. So that's why in my personal practice, when I explore the hiatus, which sometimes you need to do, especially in a big man with lots of fat pads, what I try to do is I try to do a posterior dissection and only a posterior dissection. I dissect the bottom of the left crus. I pass behind of dorsal to the esophagus until I emerge on the right side and I can see the liver. So I know then there's nothing in the way anymore. And then I can pretty much exclude or rule out a hiatal hernia. If I can't do that, then I need to do some reduction of a lipoma, for instance. Well, I do so, and I just put in a few posterior stitches. But I'm aware that the incidence of recurrent hiatal hernia is very high.
Yep.
But don't touch the esophageal membrane.
Yep. I think the buttressing issues is keep coming back. I mean, I guess I can only say from my experience that the buttressing is probably not only just for bleeding, but it's helped you to actually keep the staple line straight. And we actually routinely suture the omentum towards the greater curve, towards the new greater curve, if we can, to exert a little bit of anti-kink towards it. But then again, it's probably a bit of voodoo magic, as people said. I will open up the question to the panel. I think I'm taking up too much time, and I think I'm conscious of time as well. If there's any burning question to ask Jacques and everyone else.
Let's go on to Ramesh, and then we can entertain the questions during the surgery. Ramesh, please.
Today I am happy to introduce Professor Christine Stier. Dr. Christine was trained as surgeon in Munich in Professor Mayer's department. And in 2012, she joined Rudolf Weiner's department as a senior surgeon and directed the surgical and bariatric endoscopy. I remember in 2012, I was there in Munich, in Rudolf Weiner's unit. We had the EAES annual event there, and I was there to give a lecture, and we also had a fellowship course there during that meeting. Today, Christine leads one bariatric department within the Sana Obesity Center community, North Rhine-Westphalia. She is one of the chairs of the German Obesity Alliance and vice chair of the German Metabolic Endoscopy Association. She is a member of the IFSO Bariatric Endoscopy Committee and editorial board member of Obesity Surgery. We are eager to listen to Dr. Christine on this important topic about what should be the indications of laparoscopic sleeve gastrectomy today. Over to Christine.
Hello, respected faculty of the Virtual Bariatric University, dear Mal, dear Mohit, thank you so much for your kind invitation. It is a great honor and pleasure to be here today, and thanks for the nice intro. My question to answer today is, when is a sleeve gastrectomy the operation of choice in bariatric metabolic surgery? If you would have asked me this question in 2012, I would have answered never. But you see here a recently performed nice sleeve. The whole staple line is oversewn, and with that, the meso is attached as covering plasty in the upper third in the angle of his. On the right side, there is the corresponding cartoon of the procedure from IFSO's Atlas of Bariatric Anatomy. Anyways, in those early days of sleeve gastrectomy, the real and only metabolic operation for me was the Roux-en-Y gastric bypass, an operation with clear recognized effect on metabolism, not too malabsorptive as were BPDs. I've always been an opponent of considering a very short bowel syndrome as a surgical therapeutic goal. At the beginning of its area, I thought the sleeve was so popular because it was supposedly so easy to perform. No endoscopic suturing, just stapling, just easy, just simple. But apart of that, in these days, sleeve gastrectomy had still much higher complication rates, and leakage was a frequent problem that could hardly be controlled. Also, the rate dropped meanwhile clearly below 1%. Endoluminal drainage or endoluminal vacuum therapy was not yet well known. The term high pressure system got around slowly, but has not yet been finally demonstrated. And with regard to sleeve gastrectomy, definitely no one yet spoke of the risk of Barrett's esophagus. For me personally, the question was, what metabolic effect should it have to trim the stomach to sleeve shape? Apparently, it has this yet. Nowadays, randomized controlled trials seem to guarantee a similar effect of sleeve gastrectomy on metabolism as can be achieved with gastric bypass procedures. This Swiss study was conducted from January 2007, the early days of sleeve gastrectomy, to November 2011. This is interesting because the first summit on sleeve gastrectomy was 2007, and ASMBS adopted the procedure not earlier than 2010, but this RCT started already in 2007, and Switzerland is basically very conservative, preferring novelties.
In 5 years, 217 patients and four bariatric centers were enrolled. The final follow-up was in March 2017. The statistical result concluded that sleeve gastrectomy is not significantly inferior to gastric bypass regarding metabolic outcome. This includes diabetes, as you see, dyslipidemia, and hypertension. So far, so good, but this qualifies neither the one procedure nor the other as a metabolic operation of exclusive choice. Rather, this study implies that the same metabolic spectrum for both operations, and thus a wide latitude in choosing the right indication. Other criteria must count for the finding of the process of exclusive choice. However, a statistically significant difference in the worsening of reflux, but not even significant in the development of de novo reflux, was shown. Obviously, sleeve gastrectomy can generate problems in patients with GERD. In the search for the optimal indication for the sleeve gastrectomy, a look at functionality and pathophysiology may be a hot lead. Is function a question in volume? Is function a question of volume in sleeve gastrectomy? Probably yes. This recently published study from Strasbourg measured gastric volume post-sleeve gastrectomy and showed that with operation, there develops a rapid early gastric emptying and a slow late phase gastric emptying. Overall, gastric emptying accelerates. More importantly, an excessive resection with more than 80% of volume can obviously impair gastrointestinal quality of life. In contrast to the Swiss study here, clearly including the symptoms of de novo reflux. On the other hand, the more volume was resected, the more weight loss was achieved. This means at least low gastric volume counts for weight loss. The old principle of restriction obviously is right and works. Additionally, gastric accommodation is important for lasting saturation, both in natural anatomy and in surgical modified anatomy, as Barham Abudayev recently could demonstrate with his examination studies on gastric emptying. This absolutely counts in favor for sleeve gastrectomy, as when compared to natural anatomy overall, gastric accommodation is accelerated, but pyloric function is completely preserved, which is not the case in gastric bypass procedures. The advantage of preserved pylorus function and thus mostly muscle-controlled gastric emptying is also demonstrated by the low frequency of late damping syndrome after sleeve gastrectomy. And to be honest, who wants to drive in a traffic jam on the highway in front of a truck driver who suffers from sleep apnea, has a bypass, and just dumps? Undoubted, sleeve gastrectomy is therefore the procedure of choice in patients who need to avoid dumping syndrome, such as professional drivers or pilots. Another advantage of sleeve gastrectomy is the fact that small bowel does not need to be measured, nor is it anatomically alterated. This preserves the entire small intestine absorption pathway and duodenum as an important route of absorption in passage, and it is not excluded from food passage. Sleeve gastrectomy is therefore the procedure of choice for anyone who depends on the safety of absorption for medication, for patients with end-stage organ failure as bridging procedure for transplantation, and equally, it is the procedure of choice for patients who have a shortened small intestine function or other reasons, such as individuals with IBD. In the past, the fact that the operation is performed only on on the stomach had another great advantage. It was mostly feasible in patients with giant obesity until recently when OAGB took over. During my time in Rudolf Weiner's department, we operated on more than 180 patients, most of whom had a BMI well over 70 with a range from 71 to 93. Till 2016, the majority of these patients with giant obesity underwent sleeve gastrectomy without any major complications. Of course, it's not always easy to perform in such a confined abdominal space, but it was feasible with sleeve gastrectomy. However, the discussion is still controversial regarding the indication in portal hypertension or liver cirrhosis. In those cases, the proponents advocate exclusively the indication of sleeve gastrectomy, while on the other hand, there is a risk of mesoportal thrombosis when quantitatively reduce the venous clearance of the splanchnic area by dissecting the right curve. Dissecting the right flexure can end in drama. Sleeve gastrectomy, you might lose your liver, is therefore a wake-up call. Thus, in the future, the indication for sleeve gastrectomy for patients with portal hypertension needs increased attention due to the risk of mesoportal thrombosis. Comparing these two publications of Dr. Aggarwal from 2006 and Dr. Angrisani from 2018 show that sleeve gastrectomy is a procedure with an overall low risk profile. There is no foreign body. It is feasible in patients that need to safe resorption of drugs, and sleeve gastrectomy, of course, can always be considered as a first step procedure equally as it was in the beginning. But let me conclude. The learning curve of sleeve gastrectomy seems to be flatter than with other methods. There is published work attesting that sleeve gastrectomy has comparable effects to the bypass on metabolism. Nevertheless, the correct indication requires a comprehensive knowledge of bariatric surgery and therapy of associated diseases, and especially an understanding of pathophysiology. There are some indications that are uncontroversial, for example, end-stage organ failure and IBD, or regarding its low post-operative frequency of late dumping. In the future, mesoportal thrombosis after sleeve gastrectomy and its pathophysiology need to be addressed in more detail. At least, sleeve gastrectomy seems to be the chameleon of bariatric surgery. The effect of gastric volume reduction is supposed to be just as effective as a surgical intervention with small bowel transposition, but simply easier to perform. But is this really true? Or do we need to do more research and learn about the function of the stomach as GI pacemaker, as we have already begun to do so with the physiology of the small intestine? I think we are still at the beginning of understanding the big picture. So let me close with a quote of Socrates. I know one thing, that I know nothing. Thank you so much for your kind attention.
So thank you, Christine. It was a wonderful presentation. We've been debating about these things for almost 15 years, and we still continue to debate on what is good and what is not. A few pointers that I looked at in your presentation and that came to my mind was the function of the pylorus. How do you think that what are the advantages of having the pylorus in the passage of food, and how much does it really matter? Is it just in controlling the dumping, or would it also have some effect on the metabolic response? Because there are certain bariatric surgeons I've discussed with who feel, who are not very clear, but they feel the pylorus has some role to play in controlling metabolic response. What are your comments about that?
This is indeed a very, very good question. And my answer would be it's both. It has a pacemaker function, but also in the duodenum itself, there are receptors that measure the carbohydrates. And as you remember, there is published work that says if you have a dumping syndrome and you reinstall the duodenal passage, for example, with a tube, damping will disappear. I think the thing is that these sweet receptors in the duodenum count for example, in patients that eat a lot of carbohydrates, that the sugar isn't increasing that much after that. But this is not the case in a bypass procedure. So it's both. The pylorus is like a pacemaker, just allocating the food in portions into the duodenum. There it is measured, the carbohydrate content, and the insulin output is adapted to that. So it's both. Yeah, of course it's an important part of the stomach.
Yeah, thank you. And then you brought out a very interesting and something intriguing point about sleeve gastrectomy in cirrhotics. Not many people have been talking about this thrombosis occurring after sleeve gastrectomy. But then we always had this algorithm that we followed. If you find a patient having cirrhosis, don't choose the RYGB, but then you choose the sleeve gastrectomy. Now, if you don't do sleeve, what else would you do for these patients?
Imagine it was forbidden in Rudolph's department to do a sleeve in patients with liver cirrhosis because of this blocking of the splanchnic volume. And indeed, if you look to the literature, you will see that there is only reported mesoportal thrombosis after sleeve gastrectomy. There now was one case I personally know after sleeve pouch in esophagectomy, but even there, nothing more is reported about this problem. And I really think the quantitative venous clearance of the splanchnicus area in portal hypertension is via the right curve of the stomach, and we just have to examine this in much more detail in future.
Okay.
Of course, you can do also a medication preparation for these patients. You can give them beta blockers that improves a little bit the splanchnic volume or decreases it a little bit. But I think this is a major problem, and we have to find criteria in which patient you can do so and in which not.
Would you even go to a level saying in cirrhotics, try to avoid bariatric surgery?
No, absolutely not. As we know, it improves absolutely the liver function. No, we only have to choose the right procedure for those patients based on their personal criteria they bring in.
Yeah, and then now we see that these, Dr. Paulina mentioned, and you also mentioned about these presentations or publications about metabolic response being equal in RYGB and sleeve, which was not the understanding we had about 10 or 15 years ago. And now we're looking at 5 years, 7 years effect, both in the bariatric and metabolic. Now, what is your impression about how this would go in future? Supposing we look at 10-year or a 15-year response, would the metabolic response be good in sleeve?
I can tell you, we are just about to publish a comparison between endobaria. You know, this is this Teflon sleeve endoscopic procedure with Roux-en-Y gastric bypass. And I can tell you, we have the same effect on diabetes with the endoscopical procedure than with the Roux-en-Y gastric bypass. And this, in my point of view, demonstrates that there is really big impact of excluding the duodenum in patients with diabetes. And for me, Roux-en-Y gastric bypass is simply the gold standard in patients with diabetes, or the mini bypass, of course, too, because there is significant impact on the metabolism, much more, I think, than with sleeve gastrectomy.
Yes, thank you. Even I believe that. So we just have to wait.
At this time, we are on time, believe it or not. Normally at 40 minutes to the end, we go to the live surgery session.
Thank you,
This will be
Christine, for
moderated by Dr. Himpens, Dr. Stier, Dr. Aggarwal, and Dr. Salminen. At this time, I would invite the fellow to present the case that Dr. Mohit Bhandari is going to perform today, and I'll turn over to Dr. Mohit Bhandari. Himanshu?
Hello.
Yes? Case
Yes, sir, they are coming in.
Okay.
They are coming in.
All right, if there's a delay, I'll entertain any questions or comments from any of the faculty, please.
Yeah, sure, sir.
Well, while the oral is waiting, I would say it's been very interesting. I've enjoyed all the 4 presentations. And the one message I get out of it is that not both, but the sleeve is a very good operation, but it should be done selectively. And it is as effective as a gastric bypass in most cases. It does have a slight tendency to have lesser weight loss in the long run, but it seems like the metabolic effect is almost as good as that with the gastric bypass. That's what I get from the immediate and long-term follow-up. And that's what those who are studying the field.
Can I have a very quick comment to Christine's, because I kind of agree with the type 2 diabetes, but we don't really have the evidence to show that. From a logical point of view, the way it functions, I fully agree. That's how it should be, but that's why I'm really anxious to see maybe the 700 patients that we randomized compiled together, that will we have that effect? Well, maybe we do.
Let's see, I'm very curious.
Yes, me too.
Good. Okay, we'll go to the case presentation. Dr. Mathur is going to present the case. Winnie?
Hi, good evening, everyone. Good morning. I'm Dr. Winnie Mathur, and I'll be presenting the case details of the patient. So she's a 52 years old female with a weight of 116 kgs with a BMI of 50. And she's a non-vegetarian with the diet. She's non-diabetic but hypertensive. And we got her blood work done, where the albumin is slightly low, but rest everything looks fine. She has HbA1c 7.2 and B12 and everything, all the things look fine. And we also do a COVID test at our center, so the COVID test came negative. Now I'll give the mic to Dr. Bhandari, and he'll do the intraoperative endoscopy.
Okay, so good evening, everybody. We have a trend of doing principle of practice where we do intraoperative endoscopy for all our patients. So this is the esophagus here, and so the principle is that the intraoperative endoscopy decreases the chances of patient refusing a bariatric surgery and compliance issues. Plus, it is very convenient, and we take a consent where the patient can choose a surgery as per our algorithm, but at the same time, we can change the surgery depending upon the status of the intraoperative endoscopy. So basically, we don't do preoperative endoscopy bearing the revision cases. All fresh cases are being exposed to just the intraoperative endoscopy. This is a Z line, as you can see. The stomach is properly inflated. The Z line is at 40 centimeters. This is a stomach which does not have anything abnormal to preclude a sleeve gastrectomy. Usually it has to be a high grade of Barrett's esophagus. This is the duodenum, and when I pull my scope a little back here, I see that there are no duodenal ulcers or any polyp or any particular growth which make the things difficult. There is a little bit of gastritis mild here at the prepyloric area, you can see here, but that's okay. That does not create much of a problem. As far as what I can see here, this is a nice hiatus. I don't see any gap here, but again, we will have to take a better look while we do the laparoscopy. So this is our routine practice of doing an intraoperative endoscopy in most of our patients. We usually would do some endoscopies on the OPD basis in revision cases, because these are those cases where I feel that we can have certain surprises. And just to avoid those surprises, we do pre-operative endoscopy in revision cases. Now, our port position. So this is the port, which is the first port, a 12 mm port, which is just above the umbilicus. The optical port is here. It's not the midline port, which is optical, but it is on the left side of the port from where all the stapling is being done. So all the stapling is being done from the port, which is just above the umbilicus here. That's the umbilicus. This is just above that. The optical port is on the left side of the port from which stapling is being done. So these two ports are important. Rest are two 5 mm ports for the sleeve. We have further reduced them to 4 mm now, which are both 2 finger breadth below the subcostal margins, both in the anterior axillary line. We are using a 3 mm needloscopic instrument to retract the liver. So I stand on the right side of the patient, and my assistant is standing between the legs of the patient. We start to divide this omentum just opposite the incisura, because I think that's the area where the thickness of this omentum attached to the greater curvature is pretty less. And then we move towards the pylorus. So the dissection towards the pylorus or towards the caudal end is done first, so that we can retract the stomach properly while we go into the kypheloid area of the short gastrix. Also, sometimes when we do endoscopy, we may ask the anesthetist to remove this air by putting in a bougie, because sometimes there is a lot of air which we put in the endoscopy, and the bougie is a better way of removing that air rather than using an endoscope, because the diameter of the bougie which we use is a 38 French. It's a little larger as compared to the diameter of our endoscope. So that precisely helps in better evacuation of air which is filled inside the stomach. Now that's the liver, which is being, which we think is the margin of the pylorus, close to the caudate lobe here. So you can see that that's the pylorus there, and that's the first part of the duodenum, and that's the CBD above that. So I'm just gonna do my dissection completely until the pylorus, because we push all our gastric tubes into the first part of the duodenum. So when we have to do that, my dissection is always complete until the pylorus, close to the pylorus or until the pylorus, because it gives me a good amount of ease to put the gastric calibration tube across the pylorus into the first part of the duodenum. So you can see that I'm moving close to that area. At most times, I've seen surgeons leaving 3 centimeters from the pylorus where they do not divide. We do a partial enterectomy a little closer to the pylorus. So we do remove this. So this is the pylorus here. That's the first part of the duodenum. Here is the CBD. That's the area. So I'm just gonna do complete dissection until here. So that's the area I want to make sure is clear. A little bit of dissection here. That's fine. So that's the area of my end of my dissection at the caudal end of the stomach. And now once we go towards the kypheloid end, you can see that because I have dissected it completely, it's pretty easy for me to basically move this stomach all around, because it gets very free. And when I'm doing this dissection, I can see the retrogastric tunnel. So that's the retrogastric tunnel, which I can see pretty easily. So that's why I choose to dissect first towards the caudal end. Also, another piece of information for those who are doing sleeves And starting them is to dissect very close to the stomach, even if you burn on the stomach wall, because when you remove the specimen, it becomes that more easier, and this pad of fat does not remain with the specimen, and you don't have to dilate the umbilical port too much, which decreases the chances of hernia later on. So, and also I have seen a lot of dissection being done without dissecting the stomach towards the caudal end, and when you have these retrogastric adhesions with the pancreas, it gets difficult. So this was the retrogastric tunnel I was talking about. Now you can see very nicely here, we are able to see in that part the adhesions more closely, more clearly, and that's why I sort of dissect it in a much better way downside than coming up, so that this portion becomes much easier. Here we usually do dissection very cautiously, because there are the short gastrics, and the trick here is to just start it a little lateral. So you can see here I have this vessel here. This vessel I usually would take it with the harmonic shears. It assists in good mobilization of the stomach. Mostly these are the gastrosplenics and the gastrophrenics, but that's the stage. I'm not going to go beyond this point, because I make a hiatal defect when there already is not, and disturb that pad of fat. So I don't go beyond this in a sleeve. I feel that most of these hiatus hernias which happen in sleeves later on are basically an outcome of dissection of the gastrophrenics, where we disturb that anatomy of the stomach, doing too much of dissection at the left crus, making a hiatal hernia defect, which is not, I think it's not advisable. We have that mechanism there already. Now, as you can see, we are trying to put this tube across the pylorus into the first part of the duodenum, and because of the dissection which I did previously, I could easily put that tube into the first part of the duodenum. Now, what is the advantage of that? The advantage is that now I have my entire stomach towards the greater curvature free. If the tube is dangling here, it gives me a little bit of unease in firing this first cartridge. So all my firings are done from the midline port, which is a 12 mm, and we usually, this is a complete grasper breadth, 2.5 centimeters from the pylorus. So we usually leave that area from the pylorus and start to fire. So the first cartridge we use is a green load. We are using the gripping surface technology stapler by the J&J, and that's what we have been using frequently in our practice. And the practice of leaving 2.5 centimeters from the pylorus is very standard, which we decided. So that means that we do a partial sort of an enterectomy, and that's the routine practice at our end, which we usually do. So you can see I'll have a ruler scale now, so I can measure that distance, although this is a very rough sort of an estimate, which I usually do. But since it's a teaching case, we not going to move very fast. We will measure it, and you can see that that's 2.5 centimeters from the pylorus exactly. So now what I can do is I can start my further firings. I will keep on giving important piece of information. The other information is that this is the second firing is a little critical. This is the area where all these strictures in the sleeve would happen. So my bougie is inside into the first part of the duodenum, and I leave this area from this incisura angularis, which causes stricture. And the next load which I'm using is a blue reload. If the stomach is pretty thick, I may use a gold instead. At this stage, I am bringing my bougie in after my second firing into the stomach from the first part of the duodenum. The logic behind that is that now I can get a better help from my gastric tube once I have done 2 firings to make a nice tube, not too tight, not too loose. So as you can see, I'm not very abut to the bougie. I'm just leaving a little bit of room there, a space there for me, because I believe that it does not cause more weight loss. If you go very tight, it causes more leaks though. So that's the logic. We don't go very, very close, as you can see, to the bougie. Bougie is a very rough estimate. This is a 38 French I'm using here. It's a very, very rough estimate of making a sleeve. We usually would measure it with a ruler scale. So our breadth of our sleeve is around 2 centimeters to 2.5, and the length would be around 18 to 20 centimeters. The volume will be around 150 to 180 ml. So that's the standardized sleeve at our center, and I think we are sticking to that particular parameter since a long time now. We have not deviated from our technique. That's the same technique we utilize. So this will be the last firing, hopefully, and that's, you can see that the area close to the spleen. I'm not going very close to the GE junction. So that's it. Now about the hemostasis. So the beautiful part is that we don't suture omentum to the sleeves. We don't do running through a staple line. We just use the clips. Now, how to apply these clips to cause hemostasis? So that's the technique which I'm going to demonstrate. I think that would be more interesting part of this sleeve. Rest, everything was pretty straightforward. So what we basically do is we use clips to do the hemostasis, unlike most other centers. So what we start mostly from one of the ends where there is more bleeding, and then we either go up or we go down. So you see my assistant will hold the staple line very softly, very gently with a Maryland forceps, just like that he is doing. And I go at the base and apply these clips. So we are very satisfied with using this method of hemostasis. I know there can be debates of one method versus the other. I have seen surgeons using many different techniques, from suturing through the line to burying the line to fixing up with the omentum, to using several fancy things like Avicel or other hemostatic agents. I think we are very happy using these clips. This patient is having a little higher blood pressure intraoperatively, and we usually would like that, because I feel that a sleeve line which bleeds in front of you is much better than a sleeve line that bleeds immediate post-operatively, just when the patient is recovering from the general anesthesia and is having a high blood pressure. So this is our standard practice, that we ask the anesthetist to bring down the blood pressure to 140, and then whatever small oozing which we see, we just take care of it with the clips. We haven't changed this practice in more than 5,000 sleeves we performed till date. That's with a very minimal, less than 0.01% of re-exploration rate after sleeves. The same thing we do with one anastomosis, which has two long sleeve lines on both the ends. So that's the way. And you know, at most times, once we do this, it works. Also, once I have done the hemostasis, I'm going to remove the bougie NC, because most times the bougie can apply pressure on these vessels and then they may not bleed, but they may bleed once the bougie is removed. So then once we have done this, we'll remove the bougie, recheck again, and we'll apply the clips wherever we would want to. Sometimes I do not face any bleeding, and still I apply clips on these vessels, because I believe that they bleed post-operatively inside, and these are the cases which have a drop of hemoglobin the next day after the surgery in sleeves. So
okay, Dr. Himpens, the most senior surgeon, any comments about the surgery? Jack? Is he muted?
I think he had to go to the OR. I think he messaged in the WhatsApp group. So,
all right, Catalin, any comments about the surgery?
Yeah, congratulations, Mohit, for this surgery. It was straightforward, clear for everyone. As I said, now sleeve is a mature procedure and is ready to be applied worldwide, wider and wider. I have experience with placing clips for hemostatic reasons, and it is very efficient as it is demonstrated. But we notice that it's taking some time because you are rising up the blood pressure with the help of the anesthesiologist. And our procedure is 20 to 30% related to the previous values that you encounter to that very patient. In this case, you noticed 140. As you can see more bleeders, you have to get after them and then again clips and then clips. And sometimes we applied the 30, 40 medium large titanium clips. Two things I would like to say. One is time, and then we switched to oversewing the entire stapler line because we still had some postoperative bleedings with this technique of controlling the bleeding with the clips, because in between two clips, there were some bleeders that we couldn't hunt at that time. And then if you are not staying exactly as you demonstrate on the stapled line and you go inside to the stomach, you might have a ischemic gap there with a potential leak. This is my comment. Otherwise, my applause for your technique, if you want to say something.
Yeah,
Yeah,
no,
Dr.
exactly. There is a particular way to apply these clips. As you correctly said, you have to go perpendicular to the vascular arcade and to the veins, and only then you achieve perfect hemostasis. So I agree with you. Everybody cannot apply the clips in the same pattern as we did here. I think suturing takes more time than applying the clips. In this case, I would say it's a little more daunting. It took 2-3 minutes extra to apply the clips. In most cases, we don't need to apply these many clips, but we have been doing this and we are comfortable doing that.
I agree with you, Mohit. We would like to extend this technique in an easy way to be performed. And as oversewing is not easy, it will take time to introduce the protocol into the team. Trying to prevent the complications with this technique is something they can do tomorrow. And I agree from the educational point of view, 100%.
Yeah.
Dr. Prager, do you have any comments about the procedure?
Congratulations from my side. I do it very similar. The only thing we stopped doing is the clips. And I'll tell you why. Because we do a lot of redo surgery, and in Austria for some time, everybody was placing 20 to 30 clips, and some of these clips will migrate to the tissue, and you don't see it immediately. And I just want to mention that if you do redo surgery, check whether there are clips. You can do this either with X-ray, or you read very carefully the operating report of the previous surgeon, which you should do always, of course. But keep in mind, the clips can migrate and then you can face staple line failure. So what I do, I nowadays reestablish the gastrosplenic ligament, and that's the technique I do. So, but otherwise it's pretty the same, and congratulations. What I expected, a perfect operation.
Yeah.
So you mean that you, go ahead.
Yeah,
you suture the cut edge of the sleeve to the omentum. Is that what you mean? Gastrocolic ligament?
Not to the omentum, to the gastrosplenic ligament, where you cut it.
Mohit, go ahead with your comment.
Yeah, I think, as I said, these are all different ways. I think Dr. Fobi has been here for like almost 4.5 years, and he did a couple of sleeves. He used the same technique. We never had problems here of migration or staple line failures with this technique. So we got confident, and after 5,000 sleeves using this technique, we still follow it. But I agree, I mean, whatever makes us feel more secured, whatever has evidence, and whatever in our own data suggests safety for our patients, we should do that.
Christine, Dr. Stier, you have a lot of experience. I still remember you bailing me out of a surgery in Frankfurt when I got stuck. So what do you say about the operation?
Perfect. Congratulations, Mohit. Really perfect. We did a lot of this clipping in Frankfurt. Here in North Rhine-Westphalia, we do the complete oversewing of the staple line with adhering the meso on the upper third, which is maybe also a little bit of magic, you know, but we feel very well with that. Because if there would be a leak, it's covered directly with meso or omentum. But anyways, in Frankfurt, we did exactly the same technique and it worked very well. I agree completely with Gerhard that this may be a problem in redoing after a sleeve, but you can examine that with X-ray, and yeah, that's what I have to say for that.
Yeah. No,
Dr. Salminen, what's your experience been? Are you clipping, or sewing, buttressing? What do you do?
We actually use the first two cartridges are buttressed, and because the antral area is much thicker, so you most often have a bleeder there. But I think the buttressing material with this, we actually use the I think the Signia compared to a regular manual stapler, kind of it gives you the feeling that the hemostasis is a bit better. But we use buttressing material, and we do exactly like Gerhard said, that we actually stopped using the clips because we had some issues with the revisional procedures, that you actually ended up having quite many clips at the state that you actually wanted to do something else. So we just use the clips in case you do have a bleeder, but buttressing material for the first two, we don't oversew.
Okay, Ken, are you still here? Are you awake, or you gone to sleep?
I think he sent a message
He
that
said
he
he
was going to go
messaged that he's
sleep.
going to sleep. Yeah.
All right, I missed
Yeah.
that. Okay, then I'll ask Dr. Ramesh, any comments? I know you did quite a few sleeves, banded them.
No, it was an excellent presentation. He showed a professional surgery. The only thing is we have some old habits of suturing the whole staple line, which we are still following. That's the only difference between what we do and what he showed now. But most people today are doing what he does. The staplers were not great when we started about 15, 20, 17 years ago. But now they have improved, and a lot of people have stopped suturing the staple line.
Fantastic. At this time, I would say thank you all for the young surgeons who are listening. What you should have gotten out of this is that looking at the case mix of all the experienced surgeons, you see that they all do at least 3 or 4 different procedures. They do a sleeve, a gastric bypass, a one anastomosis gastric bypass, or a SEDI. That allows them to be able to choose the procedure and fit it to the patient rather than doing one operation alone. So what I will get from this is that the surgeries we now offer are all very effective. Some are more effective than others. And if you're going to serve our patients well, then you should be able to do more than one procedure so you can tailor the procedure to the patient. At this time, I'll ask Dr. Bhandari to give you a word of thanks, and then we'll promote the next meeting for next Monday, which is going to be on the gastric bypass. Mohit?
So thank you very much, everybody. You took time for this meeting. It was a simple issue to deal with. This was probably the simplest case I operated in almost 18 virtual bariatric universities till date, which me and Professor Fobi organized. So thank you very much, everybody. And I look forward to have a long-term association with you. Himanshu, we can play the promo now.
Okay. And for the audience, we would answer your questions at the website.